Bismillah ar-Rahman ar-Rahim. I am Dr. Ahmed from Mansoura, Egypt. We will start day 6, 7th ISN Educational Ambassadors Program in Africa, the Kernes project. And today we have a special session dedicated for the examination of histopathology of the renal biopsy. So today we are with our eminent professors of pathology, Professor Mona Abdelrahim from the Urology Nephrology Center, Mansoura University. She will talk about examination of the renal biopsy by LM and immune fluorescence, and will be followed by Dr. Mohammed Fahim. He is our consultant pathologist from London. He will give us notes on how to examine the renal biopsy by electron microscopy and the interpretation. I will start first the presentation of Professor Mona. Please be with us until I prepare her presentation.
My pleasure today to accept this kind of invitation to share this activity, the 7th program, ambassador program for nephrologists at Africa. Today I will deliver the presentation titled Histopathology of renal diseases. دكتور أحمد هو
نعم أيوة مع حضرتك. أيوة دكتورة منى أنا سامعك. مع حضرتك.
هي عندي على السكرين مش شايفه an ambassador at Africa, and today I will deliver a talk titled Histopathology of renal disease. In the kidney, we have usual four histological structure: glomeruli, tubules, interstitium, and the blood vessels. And this photo demonstrating the full structure. This is slide stand for pus stain, and we can show here the glomerulus in the middle of the section, and this is the glomerular capillaries in the inside, and all the other rounded structure are the renal tubule with nice basement membrane delineated by the pus stain, and at upper side here is the section in two arteries. And here we revise major clinical syndrome of the renal diseases. which are acute nephrotic syndrome, asymptomatic hematuria or proteinuria, rapidly progressive glomerulonephritis, acute renal failure, chronic renal failure, urinary tract infection, and nephrolithiasis. Glomerular syndrome and disorders, the nephrotic syndrome, starting for the glomerular syndromes and disorder by the nephrotic syndrome. Among the many causes that presented clinically by nephrotic syndrome, I chose this more common histological forms. First and second, minimal change and focal segmental glomerulosclerosis, membranous glomerulopathy, and membranoproliferative glomerulonephritis. The nephrotic syndrome, minimal change disease. Minimal change disease is a major cause of idiopathic nephrotic syndrome, and pathologically is a glomerular disease with minimal or no glomerular alteration by light microscopy, with no glomerular immune deposit. And the only abnormality that experienced in this disease is the extensive process effacement at the electron microscope. By light microscope, typically the glomeruli display little or no histological abnormalities. Glomerular capillary are fully patent. Minority of cases, there is mesangial prominence. The glomerular prismatic membrane appears normal in thickness, texture, and contour. Like in this photo here, this photo shows two glomeruli with patent capillary tuft and no mesangial increase and no hypercellularity, and the tubules show normal configuration. Also here a section in arterial wall and also within average fine. This is high power magnification, light microscope, and this is a glomerulus situated at the middle. And we have a very nice glomerular basement membrane. The capillary tufts are patent, and no mesangial expansion or mesangial cell increase or any abnormality. For the immunofluorescence, absence of detectable glomerular immune deposit, minority may exhibit weak mesangial deposit of IgM. The tubules show diffuse positivity for albumin, interdistribution of proximal tubular cell protein resorption droplets. Electron microscopy finding. I will not describe the electron microscopy as there is in the schedule a special lecture for electron microscopy, so I will not show any electron microscopy in this talk. Second item responsible for nephrotic syndrome, which is one of the commonest histological types, is the focal segmental glomerulosclerosis. The light microscopy finding of FSGS or focal segmental glomerulosclerosis is just a description of the name of the disease, which we can find discrete segmental solidification of the glomerular tuft. Early in the disease, segmental lesions have a predilection for the juxtamedullary glomeruli. The anatomical sign that is juxtamedullary between the cortex and the middle. A lesion may involve a perihilar region where the vascular pool lies, or it may be involved with the others.
It looks like we have issue with the connectivity, so please stay with me. I will reconnect the slide again.
and the middle. A lesion may involve the perihilar region where the vascular pool lie, or it may be involve the other side, periphery of the shaft. Some glomeruli have segmental lesion in more than one lobule, involving both perihilar and peripheral lobule. Glomerular capillary are segmentally occluded by a cellular matrix material, often associated. Like here in this photo, this is a section in the glomerulus, and here the capillary shaft is patent, like the minimally changed disease. But here we can show that the glomerulus is observed for or remarkable for this segment of sclerosis and mesangial expansion here and sclerosis. Also here there is early segmental mesangial expansion also here. This section is stained by Mason trichrome, and here this glomerulus, and this is the hilar pole where the afferent and efferent arteriole lies, and on the other side, the periphery of the shaft, we have noticed a segmental sclerotic lesion that have Mason trichrome positive in the blue color, and this segment of sclerosis with adherent to the capsule of the glomerulus and making obstruction to the urinary space. The urinary space is patent all over here and all over here, but it is interrupted at this site. And this is another glomerulus in the field where here is the urinary space is patent and not interrupted by or occluded by the segmental sclerotic. Immunofluorescence. Also in focal segmental, the immunofluorescence was not significant. A few cases may showing exhibited segmental granular deposit of IgM or C3 in the distribution of the segmental sclerotic segment or hyalinosis. Just this. This is immunofluorescence for IgM for one of the cases. This is the sclerotic segment at the periphery that interrupted the urinary space, and it's showing positive staining for IgM in immunofluorescence microscope. Next morphological item for nephrotic syndrome. Now is the membranous glomerulopathy. Primary membranous glomerulopathy, a spectrum of glomerular capillary wall abnormalities resulting from the formation of sub-epithelial deposit. Light microscope, the only finding that we notice for light microscope is glomerular capillary wall thickening seen in fully developed forms of the disease, and this is not associated with mesangial expansion, cellularity, or any abnormal, just thickening of the basement membrane. And primary membranous glomerulopathy is very unlikely, and the most common is the secondary membranous glomerulopathy. And we have a lot of conditions that are associated with membranous glomerulopathy. First group of diseases in the etiology of secondary membranous glomerulopathy, we have first autoimmune or collagen vascular disease, and under this title lie systemic lupus erythematosus, rheumatoid arthritis, mixed connective tissue disease, Sjogren syndrome, autoimmune thyroiditis, primary biliary cirrhosis, ankylosing spondylitis, and Crohn's disease. Second etiological group is the infection group, and here lie hepatitis B, hepatitis C, schistosomiasis, malaria, or filariasis. Next group of etiological agent for membranous, secondary membranous glomerulopathy, we have medication, many medication cause this membranous glomerulopathy. Among them, we have penicillamine, gold salts, trimethadione, or bucillamine. Also, it's very common association of membranous glomerulopathy with neoplasms. Malignancy is a common association for membranous, like visceral organ, like colon, lung, breast, stomach, pancreas. Any carcinoma is very common association. Also, other like melanoma, Wilms tumor, lymphocytic leukemia, Hodgkin disease, and non-Hodgkin lymphoma as well. Also still have another etiological agent for membranous glomerulopathy. In the miscellaneous group, there was sarcoidosis, it can cause membranous glomerulopathy, sickle cell disease, Guillain-Barré syndrome, angiofollicular lymph node hyperplasia is known as Castleman disease. And this is the light microscopy of the membranous glomerulopathy. We have here this glomerulus in the middle of the section, and we here have another one. And the glomeruli is observed for thickening of the basement membrane, like here and everywhere. And actually, in every segment, we notice that the glomerular basement membrane was thickened, and no increase in the mesangial matrix or mesangial cells. This is a silver staining that highlights the second basement membrane. Also, it highlights the double contour. We can here show that the basement membrane have two outlines, outer outline and inner outline, and this is the tram-track appearance or double contour of the thickened basement membrane. This is immunofluorescence of IgG and show diffuse high staining pattern immunofluorescence for IgG, that the whole shaft is remarkable staining at the maximum staining intensity for IgG. This is higher magnification, and here we can show the two. This is outer basement membrane, and this is the inner basement membrane of the second glomerular basement membrane. Now we shift to the pathology of acute nephritic syndrome. And also we have many histological pattern involved in this category. The group here to be presented in this lecture, also we have membranoproliferative glomerulonephritis that could be presented as nephritic and also could be presented in the previous group of nephrotic. So MPGN could be presented with nephrotic or nephritic. Second item, we have acute post-infectious glomerulonephritis, and this is post-infectious is an old name. The most common usually updated name is acute diffuse proliferative GM. IgA could be presented by nephritic syndrome, and here is a group of secondary or systemic diseases like systemic lupus erythematosus. And lastly, that could be presented by acute nephritic syndrome, the rapidly progressive glomerulonephritis or the crescentic glomerulonephritis. And in this group, we have three items: anti-GBM, immune complex glomerulonephritis, and the multi-immune glomerulonephritis. MPGN. The pathological alteration, now we have more complication in the morphology or the glomerular involvement. First, we have in the minimal change, no abnormality. In the FSGS, we have just mesangial expansion, and in the membranous, we have thickened basement membrane. Now we have more complex abnormal pattern in the glomeruli, and here we have pathologic alteration of both mesangial and the peripheral glomerular capillary walls. The changes tend to be diffuse or global, but in mild disease, it is more focal and segmental. Glomeruli often display accentuation of lobulation, as we can describe here in this image. This is a glomerulus here, and it showed accentuation of lobulation by means of segmentation. Like here, this is a segment, and this is another segment, and here another segment, and there are a lot, in spite of one integrated capillary tuft as one segment. No, here we have accentuation of lobulation. Also, we have mesangial expansion here, like highlighted in this pink color. So we have accentuated lobulation, mesangial expansion, hypercellularity, increased marked increase in the number of cells inside the glomerulus, which are mesangial and endocapillary. Beside this, we have thickened basement membrane. This thickened basement membrane and the mesangial expansion causes encroachment on the capillary luminal area that we are noticing here. This is a narrowed capillary, narrowed, and some about to be obliterated and very narrow, like here and here. And this is usually associated with hypertension, the cause of narrowing or encroaching on the capillary lumen. Second category in the nephritic group is the post-infectious glomerulonephritis of acute diffuse proliferative glomerulonephritis. Post-infectious glomerulonephritis or acute diffuse proliferative is caused by acute, usually self-limited infection, in which case the term post-streptococcal glomerulonephritis. It is characterized by numerous neutrophils, and here the term acute, because the presence of neutrophils, endocapillary hypercellularity, so the term proliferative, affecting all glomeruli. It is diffuse. Eosinophils may be present and are contributed for endocapillary hypercellularity. In this figure, we have here, this is the capillary lumina, and in this, in all the segment, we observed for intracapillary presence of leukocyte or neutrophils inside the capillary lumen, and this is the endocapillary hypercellularity. Is associated with red blood cell cast, and this shows patient exhibiting hematuria. In the course of post-infection, first, there is a loss of neutrophils and opening of the lumen that was engorgement and occluded by numerous number of neutrophils that have been narrowed by endocapillary hypercellularity and the leukocyte influx. Second 2 weeks, 75%. In the first 2 weeks of the course, most of the endocapillary hypercellularity was composed of neutrophils, 75%. Through is a post-infectious glomerulonephritis of acute diffuse glomerulonephritis. Post-infectious glomerulonephritis or acute diffuse proliferative caused by acute, usually self-limited infection, in which case the term post-streptococcal glomerulonephritis. It is characterized by numerous neutrophils, and here the term acute, because the presence of neutrophils. Endocapillary hypercellularity, so the term proliferative, affecting all glomeruli. It is diffuse. Eosinophils may be present and are contributed to endocapillary hypercellularity. In this figure, we have here, this is the capillary lumina, and in this, in all the segment, we observed for intracapillary presence of leukocyte or neutrophils inside the capillary lumen, and this is the endocapillary hypercellularity. Is associated with red blood cell cast, and this shows patient exhibiting hematuria. In the course of post-infection, first there is a loss of neutrophils and opening of the lumen that was engorgement and occluded by numerous number of neutrophils that have been narrowed by endocapillary hypercellularity and the leukocyte influx. Second 2 weeks, 75% in the first 2 weeks of the course, most of the endocapillary hypercellularity was composed of neutrophils, 75%. Through a period of 3 to 4 weeks, the neutrophils reduced number into 20%. After 6 weeks, no non-neutrophils, and the course of this disease is self-limited. As the neutrophil disappear, the complex endocapillary hypercellularity simplifies to pure mesangial hypercellularity with variable mesangial matrix increase that may persist for several years. Patient, finally, the glomeruli recovers their normal histology, and most destructive inflammatory lesions evolve into focal segmental patches of sclerosis, and this is a healing stage. Active glomerular inflammation persists longer than 6 months, raise the possibility of infection other than post-infectious glomerulonephritis, because this condition have a self-limited and short course. The second item in the nephritic group is the IgE nephropathy. IgE nephropathy is a glomerular disease in which glomerular immunostaining for IgE. This disease is diagnosed by immunofluorescence. So we should have glomerular immunostaining for IgE more intense or equal intense as staining for IgG and IgM, except in patients with SLE, in which the dominant or codominant IgA staining is considered to be lupus nephritis with extensive IgA nephropathy. This glomerulus here exhibited in this segment, we have mesangial expansion associated with segmental mesangial hypercellularity. Here, the hypercellularity resulting from the mesangial cells. But the capillary, no inflammatory cells inside, and the capillary here looks normal, and there is no thickened basement membrane, just only segmental mesangial expansion and hypercellular, and this is typical picture or typical pattern of IgA nephropathy. This is the immunofluorescence, and we notice here for IgE, this is staining for IgE, and here we notice that moderate to strong staining and at the mesangial. Here the staining for IgE is the mesangial side. No staining at the peripheral capillary wall. Just staining is restricted to the mesangial area. Now we'll shift it to the next item of nephritic syndrome or acute nephritis presented. This is systemic lupus erythematosus. Lupus is a systemic autoimmune disease that affects multiple organs, including skin, joint, kidney, serous membranes, lung, and central nervous system. And this is all the by WHO that involved here the 5 classes of lupus nephritis. Class 1, normal glomerulus by light microscope, immunofluorescence, and EM. Class 2, purely mesangial disease, looks like IgE, normocellular mesangium or mesangial deposit by immunofluorescence and or EM. Mesangial hypercellularity, mesangial deposit by immunofluorescence and or EM. Class 3, the focal proliferative GM with less than 50% affection of the glomeruli. Class 4 is like class 3 proliferative GM but it is diffuse, involved more than 50% of the glomeruli. And the class 5 is the membranous glomerulopathy class. The working classification that we use now in pathology lab for classifying lupus nephritis at the renal biopsy, we utilize the ISNEAP classification, Renal Pathology Society, that published 2003, that published at the year 2004. And we have here class 1, minimal mesangial lupus nephritis, very minimal or normal looking renal biopsy. For class 2, it is mesangial proliferative lupus nephritis, mimicking IgA nephropathy. Class 3 and 4 is the lupus nephritis proliferative. For class 3, it is and class 4, it is diffuse. Class 5, the membranous lupus glomerulopathy, and the class 6, advanced sclerosing lupus nephritis with more than 90% of the nephron involved where glomerulopathy is used. And this is the stage of end-stage renal. Glomerular pathology, according to ISN classification, class 1, minimal mesangial lupus nephritis, and here this looking like minimal change disease and no immunofluorescence or EM abnormality. For class 2, just we have segmental mesangial expansion associated with minor mesangial hypercellularity, like here and here, then this is class 2. Class 3, focal lupus nephritis, and the class 4, diffuse lupus nephritis. The glomerular lesion of class 3 and class 4 lupus nephritis are qualitatively similar, differing only in severity and distribution. Definition of class 3 lupus nephritis is a focal segmental or global endocapillary proliferative GM affecting less than 50% of the total glomeruli sample. Class 4 lupus nephritis is diffuse segmental or global endocapillary proliferative GM affecting more than 50% of the glomeruli. And here, this is lupus nephritis class 3. We have in this photo, we have shown that this segment of the glomerulus have patent glomeruli, no thickened basement membrane, no mesangial expansion, no hypercellularity. But here in this segment, it is markedly affecting, have mesangial expansion, mesangial hypercellularity with increase in number of mesangial and endothelial cells, and we have endocapillary inflammatory cells with neutrophils here and here and here. And in this segment, we have the severest lesion that could occur in a glomeruli, which is fibrinoid necrosis, or this is a sort of vasculitis. Here, in the fibrinoid necrosis, this is severe nephritis, have multiple lesions of lupus nephritis, mesangial expansion, hypercellularity, endocapillary leukocytic exudate, and fibrinoid necrosis with karyorrhexis or fragmented nuclei of the mesangial cells. This is a case of class 3 or class 4 lupus nephritis. That is, here have fibrinoid change with fibrin oxidation and early crescent formation. That is here, it's a very nice finding. This is staining for fibrinogen that we, after occurring of fibrinoid change and the elaboration of fibrin, and early or starting crescent formation. This is a nice photo for a case of lupus nephritis class 4. And this glomeruli is hugely remarkable for pathology. He is very clear here is lesion or huge thickening of the basement membrane and immune deposit appear at the light microscope. Here the mesangial texture is replaced by immune deposit, and this is wire loop lesion, and here is the wire loop lesion that distributed elsewhere. And here is the mesangial expansion and mesangial hypercellularity. Here is huge mesangial expansion that encroaching the capillary area and including and or obliterating the capillary lumina. Also here is mesangial proliferation or hypercellularity. And here we have hyaline thrombi, intracapillary thrombi. This is also another case of lupus nephritis class 4. And the glomeruli is remarkably altered histology, completely different. We have here huge mesangial expansion and hypercellularity. This area, the capillary lumina, like here, it's completely encroaching, that's nearly occluded by the mesangial expansion and the hypercellularity, and here hyaline thrombi. And at this segment, we have cellular crescent also involved from here up to here. This is cellular crescent. And here, this case of class 4 lupus nephritis, and this is the immunofluorescence for the complementary, and we have
I'm sorry, there is a halt in our connection, so I will share the presentation again.
also here is mesangial proliferation or hypercellularity. And here we have hyaline thrombi, intracapillary thrombi. This is also another case of lupus nephritis class 4. And the glomeruli is remarkably altered histology, completely different. We have here huge mesangial expansion and hypercellularity. This area, the capillary lumina, like here, it's completely encroaching, that's nearly occluded by the mesangial expansion and the hypercellularity, and here hyaline thrombi. And at this segment, we have cellular crescent also involved from here up to here. This is cellular crescent. And here, this case of class 4 lupus nephritis, and this is the immunofluorescence for the complementary, and we have large masses or lumpy masses that distributed all everywhere in the glomerular mesangial and subendothelial and subepithelial site, and this is coarse granular deposit for complement number 3. And this is another case stained for IgG and also have diffusely distributed immunoglobulin G deposit along the capillary wall and the mesangial and subendothelial and subepithelial, and we show here the cross subendothelial lesion and here, and this is the mesangial or capillary wall lesion. Class 4 lupus nephritis or nephropathy is for membranous nephropathy, and as described before in the nephrotic syndrome, the only abnormality for the membranes is just thickening of the basement membrane by a subepithelial deposit, and this will be highlighted in the lecture of electron microscopy. And here, this is a photo of a case of class 5 lupus nephritis nephropathy, and we have just thickened basement membrane, not associated with mesangial alteration or hyper. By the silver stain. Next class after nephrotic and nephritic. This is a group of acute renal failure, and here lies example of ANCA disease, vasculitis, non-ANCA, thrombotic microangiopathies, diseases affecting endothelium, hypertensive renal disease, and thrombotic and embolic diseases. And here in this photo, this is a section in a glomerulus, and the glomerulus here is studied for a huge circumferential crescent. Here is the boundary or the Commons capsule, and all these cells are a cell of cellular crescent, and the shaft, the glomerular shaft, is just restricted here to this segment. And in this shaft, we notice here is a focal segmental necrotizing glomerulonephritis, and this is a very clear example for ANCA-associated glomerulonephritis with focal necrotizing glomerulonephritis and the huge cellular crescent obliterating the capillary function. The next group of chronic renal failure, we have hypertensive renal vascular disease. And here we have example of hypertensive patient. This glomerulus here showing normal morphology. We have no glomerular arteration, but we have here this artery is remarkable for myofibrointimal proliferation, and that's here we consider here this segment is considered this segment normal. We have the onion skin or smooth muscle proliferation here and here, and associated with fibroedematous or intimal fibrosis, and this is an example of a hypertensive vascular disease. And the second most common item in this group of chronic renal failure, and this is the most two common causes of chronic renal failure, the hypertensive renal vascular disease and the diabetic nephropathy. The most important glomerular lesion for diabetes, we have capillary basement membrane thickening, diffuse mesangial sclerosis, or nodular glomerulosclerosis, that is known as Kimble-Steil-Wilson nodules. The glomerular capillary basement membrane are thickened throughout their entire length. And here we have an example of nodular glomerulosclerosis. This is the nodular of Kimble-Steil-Wilson nodule. This is the mesangial nodular sclerosis of diabetic glomerulosclerosis, Kimmelstein-Wilson lesion, or deposit of laminated matrix situated in the peripheral of the glomerulus contained trapped mesangial cells, like here and here. And here we have the capsular drop lesion of the diabetic, and the glomerular tuft here is subtotally sclerotic, and we call for this an obstructant glomerulus with the hyaline cap and capsular drop lesion. Renal atherosclerosis and arteriosclerosis of diabetic nephropathy. Here is the afferent arteriole, and this is studied called nodular hyaline chain, and this is another small artery and is studied for nodular or diffuse hyaline change, and this is classic diabetic nephropathy. And I thank you for this.
Thank you very much, Dr. Mona, and I apologize for the frequent interruption of the internet. It is not in my hand. Next, I will go forward immediately to the presentation of Dr. Mohammed, and we will keep the discussion at the end, inshallah. So the next presentation for Dr. Mohammed, he is a consultant of pathology from London, and he will speak about the EM examination, how we as a nephrologist can understand the interpretation of the AM. Dr. Mohammed, are you going to make it live, or shall I display the recording? Dr. Mohammed, can you answer me? Please unmute yourself, Dr. Mohammed. Yes.
Thank you very much. I'm just start sharing my screen.
So, are you going to be live? You will present your live.
Right. Thank you very much. Okay. Thank you, Professor Mona. It was an excellent presentation with very clear images, and you made my task very easy. Thank you very much. Now, right at the beginning, I must thank Professor Ahmed Akel and ISN for inviting me to participate in this important educational activity, which is transcontinental. So let's start off without wasting any more time. My affiliations, very quickly, I'm a consultant director, Urologics Limited, based in London, UK, and also I'm a consultant renal histopathologist for Excellence Med Laboratories in Bahrain. I used to be a consultant renal histopathologist at Kaiser St. Thomas's Hospitals and a clinical senior lecturer at King's College Medical School in London. A brief disclosure, most of the material in this presentation is from my forthcoming ebook, Kidney Biopsy Pathology, a manual. Therefore, it will be subject to copyright to the publisher. Abbreviations used, because I may rush quickly in my presentations. So most of the abbreviations I'm going to use are well known. EM is for electron microscopy, electron microscopic, GBM for glomerular basement membrane, IF for immunofluorescence microscopy, and LM for light microscopy. Let me begin with the entire process of diagnosis of kidney biopsy that will help us look at the define the position of electron microscopy in the process. So the biopsy is taken here, and that's the end point here, a morphological diagnosis. A morphological diagnosis should describe adequately the state of the renal tissue. It should try to identify, in fact, underlying pathological process and render a proper diagnosis that helps the clinician make decisions about treatment of the patient and may give a hint about indication about the prognosis of the patient, renal prognosis, and so on. So that is the diagnosis, the aim we are trying to reach. The biopsy is taken, it goes to the lab, and the lab will process it to wax the formalin fixed sample for light microscopy, and frozen section often in Michel's solution, Michel's medium, to IF, immunofluorescence. And some labs, instead of IF, they use immunoperoxidase. The result is more or less same. Now, in many biopsies, or at least in some renal biopsies, EM is not required. So examination of LM and IF samples can lead to a good morphological diagnosis. EM is not required. So EM is not essential in all cases. However, in many cases, often with mutual consultation between the renal physician and the histopathologist, it is decided to undertake electron microscopy. And electron microscopy may be taken because it's considered essential, or sometimes it adds, it's not essential, it adds important information to the light microscopic diagnosis. So this is the second pathway. After EM, it may be possible then to render a diagnosis. There is also a third pathway in which electron microscopy raises further questions and asks for further investigation. And these investigations may range from just simple, more clinical history to serology, genetics, biochemistry, and molecular biology. And after these investigations are completed in the light of electron microscopic examination, then a final diagnosis can be rendered. So there are three pathways, let's say. Some biopsies, renal biopsies, will not require EM. Some will require EM that may be essential or may add to information, and some may require EM, but EM will then dictate further investigation. And after these investigations are done, we can reach a useful diagnosis. Now, let's look at the utility or usefulness of EM in kidney biopsy diagnosis. Now, please note that these figures in this column are taken as an average from various publications. So you will not find this figure in a single publication. I've taken an average of several papers to reach these figures. Let's look at the pediatric renal biopsy. In pediatric renal biopsies, it's considered essential. Electron microscopy is considered essential for diagnosis in nearly 2/3 of cases, whereas it adds to diagnosis or confirms the diagnosis in about 1/4 of cases. When we come to adult kidney biopsies, the situation is more or less reversed. It's essential for about 1/3 of cases for diagnosis, and it may confirm right to diagnosis in about 2/3 of cases. Important point to remember that you cannot predict how useful the EM is going to be in an individual case. So at the time of the biopsy, you've taken the biopsy, that time you cannot know whether this biopsy is going to require EM or not. Therefore, what is the best policy for renal physicians to do? Best policy is to take a sample for EM in all cases. Take an adequate sample, fix it a proper fixative, keep it, process it if it is required, because you can't go back and try to do EM from IF sample or from sample fixed in formalin. You can't do EM optimally. You can do EM, but the results will not be that satisfactory.
Mohammed, excuse me, your slides is not moving.
It's not moving. Oh.
Yeah, we are just we are seeing the first slide only.
Okay. Oh my God. Let's see. Shall I start again? So you're not getting the.
If you want me, I can start the recording and then we can continue on the discussion live. Because also we are facing a very poor net in Egypt here.
I have to go for translation. I have to go for, I have to move the bar, isn't it? This bar is covering. Sorry.
You can reshare again. Sometimes when you reshare again, it will work.
Yeah, I know. Let's see this.
Now it is moving. When you moved the slides, I saw it changing.
No, this slideshow. I'm starting slideshow.
Okay.
It's not language. I'll just. Shall I then? Hang on a minute. I'll get someone to have that. Marcel?
So I'm sorry, we will wait for a few minutes until Dr. Muhammad adjusts his slides.
I'll just stop sharing and do it again, right? Shall I stop sharing and do it again?
Can you start this? Yeah.
I'll start again. Yes, stop sharing. This is the one. But it is not allowing me to start the thing. First stop sharing.
If you can start show again and
Yeah.
share again. Yeah.
It's not showing the thing, you know. It is covering that. Do this one. Yeah. She covers the thing.
Yeah, now we can see your slide. I can see your slide again.
I'll just start the slideshow, right? Okay, from beginning. It's not showing. It's not showing.
Yeah, I cannot see a full slide. I only see half of your slide.
No, yeah, that's because we are using multiple monitors. But anyway, yeah, we'll just start this.
Now on the screen, only one word slideshow.
Just covering the thing.
If you are facing problem with this one, I can start the recorded movie.
Slideshow from beginning, from beginning. Slideshow. It's not start slideshow. No. Oh yeah, no. I will now stop share. You are now sharing. Okay, let's see. Is it working now?
I did not see. I am still seeing the PowerPoint, not the slideshow.
It's a slideshow.
Yeah, now it is working. It is working, Dr. Muhammad. Go ahead.
It's working. Okay,
it's working.
So when should I start from? Now it's working?
From beginning, because we did not see any slide. It was only the title.
Okay. Sorry, sorry. Yeah, so
no
I'll start by thanking Professor Akhil and ISN letting me participate in this important meeting. And then my affiliation briefly, I'm a consultant and director of Virologics Limited based in London, and a consultant renal histopathologist for Express Med Laboratories in Bahrain. I used to work as a consultant renal pathologist at Guy St. Thomas's and as a clinical senior lecturer at King's College Medical School in London. Brief disclosure, most of the material in this presentation is from my forthcoming ebook. It's known as Kidney Biopsy Pathology, a manual as a for. It is subject to copyright, which is owned by the publisher. Abbreviations used are EM for electron microscopy, GBM for glomerular basement membrane, IF for immunofluorescence microscopy, and LM for light microscopy. Now, let's begin with the way we diagnose make a diagnosis of kidney biopsy. The biopsy is taken here, and that is the end point to render a morphological diagnosis that should explain the state of the kidney tissue, that will also try to identify the underlying pathological process and offer a diagnosis that explains the clinical situation. And for the nephrologist, the diagnosis should inform the nephrologist about the management choices and give a hint about indication about the prognosis of the disease. So that is the morphological diagnosis. That's the aim we are trying to reach. The biopsy is taken in the lab. It will be processed for the wax, the formalin fixed sample, and a frozen section or section in Michel's fluid medium will be processed for immunofluorescence. It will be frozen and processed to immunofluorescence. Some lab will use immunoperoxidase, but that yields similar results. Now, in some renal biopsies, EM is not required. After examining LM and IF slides, the pathologist is able to render a diagnosis, morphological diagnosis. So EM is not essential in all cases. However, in many cases, often with a mutual consultation between the renal physician, nephrologist, and the pathologist, it is decided to undertake electron microscopy. That may be considered essential for diagnosis, or it may add further information to the light microscopic findings. And in that case, after looking at these electron microscopic images, it is possible to render a diagnosis. In some cases, there's a third pathway. And in those cases, electron microscopy raises some questions which have to be sorted out by further investigation. Now, these may range from just simple, more clinical history, or serological investigation, genetics, biochemistry, or molecular biology. And after undertaking these investigations in the light of electron microscopic findings, it may be possible to render a diagnosis. So there are three pathways, basically. EM is not required in all cases. EM is done, performed, and then diagnosis is entered. Or EM selects which investigations are required, and then a diagnosis is reached. So these are the ways. This explains actually where the electron microscopy lies in the entire diagnostic process of a renal biopsy. Now, let's consider what is the usefulness or utility of EM in kidney biopsy diagnosis. Please note that these figures in this column here, I have tried to take an average from various publications. So in a single paper, you will not find these figures. I may take an average from several publications. So let's look at the pediatric biopsy. In pediatric kidney biopsies, EM is considered essential for nearly 2/3 of cases. And it confirms or adds to diagnosis in about 1/4 of cases. In adults, however, the EM, the situation is more or less reversed. It's essential for diagnosis in 30% of cases, and confirms or adds to diagnosis in about 60% of cases. Now, I should add here that we are considering native kidney biopsies at this stage, native biopsies. And this part of my text, my public presentation is mostly about native biopsies. Now, what is important to remember, the usefulness or utility of EM cannot be predicted for an individual case at the time of biopsy. Time of biopsy, you cannot say whether EM is required or not. Therefore, what is the most prudent course? What's the best policy for a nephrologist to take? The renal physician, therefore, take a sample for EM in all cases, fix it properly in glutaraldehyde, preferably, and keep it, reserve it. And you can process it if it is required, because if you don't take a sample, then going back to ask the lab to process from the wax sample or from the IF sample does not lead to very good EM images. It does not give rise to good EM preparation. So there is always suboptimalness in those cases. The best policy is to take electron microscopy sample for electron microscopy in all cases. Now, let's look at the congenital disease in detail. EM, as I said, is essential in most cases. It's a key in non-syndromic cases. What do I mean by this? Take the example of nail patella syndrome. I mean, this syndrome will be seen with sort of dysplastic nails and abnormal patella, and sometimes iliac bones are abnormal, other abnormalities. And in some cases, these extra-renal manifestations may be totally absent. In those cases, EM is the first investigation that identifies nail patella syndrome. And then that dictates you do look for the NMXB1 gene and look for family history. Keep in mind that nail patella syndrome is not uniform in presentation. In some cases present very late in life. So in those cases, non-syndromic cases, EM becomes very key, essential diagnostic process. And in heterozygous cases, for example, in Anderson-Fabry disease, which is X-linked, females who are heterozygous may not have the cardiovascular complications. And the only findings, the key findings will be, the first finding will be abnormal EM showing those typical Myeloid figures, which raises the question, and then the females are diagnosed, further investigated, genetic investigation, and then the male members of the families can then be traced. So in these cases, EM becomes key. And And also, EM often decides to select which further genetic or other investigations are required. Take example FSGS. A total of 11% of all FSGS cases will have genetic abnormalities underlying them. But if you look for the genes, there are 109 genes approximately which underlie FSGS. You can't do that. You can't look for 109 genes in an individual case. If you do EM, that will narrow down the genetic investigation for mutation, for fewer genes, and then it becomes more logical and practical to do it. So EM then decides to select, makes it more logical to undertake further investigation. Now let me start off here by showing you a capillary loop. Most of the electron microscopic abnormalities in kidney biopsies are based in glomerular, but few are in tubules, which I will see examples of. Now, this is a typical normal glomerular capillary loop here. That is the GBM, or glomerular basement membrane. That's the capillary lumen with an RBC in it. The GBM, glomerular basement membrane, is trilaminar. This is internal. The internal endothelial layer, which is fenestrated. Then follows the all-important lamina densa, so-called lamina densa because electronic dense. This is composed of type 4 collagen. And then type 4 collagen can have several types of alpha chains, as you know, alpha 1 to alpha 6. And then outlying this is the third layer of these foot processes that belong to a cell called podocyte, an octopus-like cell, which throws out its feet, legs, and then each leg then branches out. And then these foot processes emerge from it. They're neatly organized on the outer surface of GBM. And then of course, the mesangium lies on one side towards the hilum, and there's a mesangial cell nucleus. The flow of plasma filtrate is this way across the GBM into the urinary space. Now, let's look at some of the examples of EM, which is essential in diagnosis of congenital heart disease. Some examples of congenital heart disease. I'll start off with this fairly not infrequent disease, thin membrane disease, which often presents with asymptomatic microscopic, often hematuria with normal renal function quite early in life, often discovered in a screening process. And these patients have a diffuse thinning of basement membrane. And because it is diffuse, we have to use a randomization method. We impose a grid on the electron microscopic image, and then you select in each grid by a mathematical formula where to measure them. And here it is 197 nanometer, 177 nanometer. Whereas in adult males, the mean is about 330 nanometer, and females 305 nanometers. And in children, it should be reached about 11 or 12 years of age. Normal thickness, adult thickness should be reached. Now, alpha genetics always are recommended in these cases. Why? I'll explain in my next slide. This is the other example of GBM abnormality. Here is the normal for comparison. The lamina densa is single layer, monolayer, whereas here you can't identify the single layer lamina densa. It is split into various layers, which anastomose with each other, giving rise to this basket view appearance, and also some granulation, widening of the whole lamina GBM at this level. And also you notice the bumping or scalloping on the outer surface of the GBM. Mutations of alpha 3, 4, or 5 genes are commonly seen in these type 4 collagen are seen. And this condition is actually underdiagnosed, especially in females. Females may be carrier or may have autosomal Alport syndrome. Now, many of the cases of these mutations will manifest as thin membrane disease. So in all cases of thin membrane disease, ideally, you should carry out genetic information, a genetic mutational analysis. So this is how EM directs you which genetic studies should be carried out, even in cases of thin membrane disease, which is not an infrequent cause of hematuria. The another example is a rather rare example of nail patella syndrome. This is the line which explains the GBM That's the podocyte here, and that's the endothelial surface, vastly thickened. The GBM itself has big lacunae, empty spaces, and within these spaces lie these collagen fibers. So this is a case, in fact, who had an actual case who had non-syndromic presentation, no nail abnormalities, no bone abnormalities, but has an LMX1B gene mutation. EM was the one which diagnosed the condition and led to the further investigation. Another case is this Anderson-Fabry disease. Again, is because of a deficiency of alpha-galactosidase A enzyme, and these because of that deficiency, you have accumulation of glycosphingolipid within the lysosome, so-called zebra body or myelin figures, and the gene responsible is this. Again, as I said earlier, if the heterozygous female, they may not have any cardiovascular abnormalities, so Fabry's disease remains undiagnosed unless you do EM and find it out. Now let's go on to acquired sort of native kidney diseases where it is essential electron microscopy. The first disease is minimal change disease. It's not, again, not an infrequent disease. The peak incidence, of course, is in childhood, and also there's a second incidence in later life. It is a disease which is not often biopsied in children, because if the patient responds to steroid therapy, there's no need to biopsy. But only when the steroid therapy doesn't work, steroid resistant or steroid dependent cases, a biopsy will be done. Now there is a normal capillary loop for comparison. You see the neatly arranged podocyte food processes there, whereas here there are no food processes seen, completely effaced, merge with each other, and this food process effacement is a very important feature of minimal chain disease. So EM is essential because minimal chain disease on light microscopy is normal on light microscopy. Of course, history helps, but unless you do EM, you cannot confirm that diagnosis. Another example is a very common condition, diabetic nephropathy. Now, diabetic nephropathy has been graded as by Leiden classification into 1 to 4, class 1 to 4. Classes 2 to 4 can be diagnosed easily on light microscopy. The class 1, the earliest one, as my previous speaker had pointed out, is diagnosed by measuring GBM thickness only by electron microscopy. Notice this case. Here you have GBM is 740 nanometers here. It's grossly more than twice the normal thickness, and is fairly diffuse. Now, these patients at this stage may have only microalbuminuria, may not be picked up the usual proteinuria test. So it's very important to diagnose them. It's early GBM changes in diabetic nephropathy only by electron microscopy. Another condition is dense deposit disease, which falls into the spectrum of C3 glomerulopathy. It's not a common disease. It can be suspected on the basis of light microscopy, especially the TAS stain section. But for diagnosis, you have to do an EM to identify this dense deposit, which is often interrupted. So you see this dense deposit goes on here. Sorry, I'm missing my point. And then here, lamina densa is normal. And these dense deposits are, in fact, deposits of membrane attack complex C5 to 9. And the condition has resulted from abnormal regulation of alternative complement pathways. You get some mesangial deposits as well. Now, another important group of conditions where EM may help are MGUS and MDRS. MGUS, of course, is monoclonal gammopathy of undetermined significance because there's no evidence of any tissue involvement. So kidney biopsy, light, IF, and EM will be negative. Whereas when kidney is involved, in addition to the presence of monoclonal gamma globulin, monoclonal peak with renal involvement is seen, and light and immunofluorescence microscopy may identify the existence of MDRS, but EM actually defines the lesion because many types of lesions can be seen in NGRS. Now, amyloid comes to the mind first. Now, amyloid is very easily identifiable in most cases by light microscopy, very easy to identify it. Typical eosinophilic appearance and typical congruent positivity with green birefringence, easy. But now the emphasis is on diagnosing early light chain amyloid or other amyloid very early on. This is an actual case in which we were not sure whether kidney was involved or not. I apologize for the fuzziness of this congruent stain preparation. I had to enlarge the specimen magnification. That's what's causing this fuzziness of the image. And you can just find some congruent positivity. We're not sure, in fact, this is amyloid or not. You see, so EM and no problem. See, capillary wall is layered with this deposition here and here as well. See, it's not uniform everywhere, but it's seen in most capillary walls. And at higher magnification, you see the typical randomly distributed unbranched fibrils of 8 to 12 nanometers in distribution. So it was easy diagnosis. Why is it important to recognize early amyloid? Because now trials are going on that may result in arrest of progression of amyloidosis. So it's very important for pathologists to recognize early amyloid, to diagnose early amyloid deposition, if possible. A related condition to it, morphologically, is uncommon one, which is fibrillated granulopathy. Here, you find similar fibrils, similar to amyloid, randomly distributed, unbranched fibrils, but they are thicker, 12 to 24 nanometers in size. And this was a difficult diagnosis to make, but more recently, antibodies, this heat shock protein, DNA JB9, it has come into play, and it is known that this is only positive so far in fibrillated granulopathy. To make it more complicated, they're usually congruent negative in this case. Sometimes they are congruent positive as well. So combination of EM, and of course, EM then dictates, ask for this stain, and then that pathway you follow, and you can make a positive diagnosis of fibrillated granulopathy. Light chain deposit disease, usually a kappa light chain excess, monoclonal kappa light chain, gives rise to this distinctive deposition of this powdery granular material just under the endothelium. It's a continuous layer, more or less. And you don't see this in any other condition. And sometimes you also get mesangial deposits. Rarely it could be, less commonly, it could be due to lambda light chain. And also the tubules, the tubular basement membrane also have very similar deposits. And this is one of the examples of tubulopathy I'll be showing you, where EM can help. And in this particular case, again, more commonly with kappa light chain excess, monoclonal kappa light chain, you see the deposition of light chain within the cytoplasm of proximal tubules. And in this case, they have formed crystal. So it's called light chain proximal tubulopathy with crystals. And sometimes they don't form crystal, then in that case, it is light chain proximal tubulopathy. And in many of these cases, there is acquired Fanconi syndrome because of the tubular dysfunction. Again, a diagnosis which cannot be made confidently without electron microscopy. Now, let's look at the conditions where EM is not essential, but it adds to diagnosis. And a common condition, membranous glomerulopathy, can be divided into primary and secondary. The primary can be identified easily by plateau R staining, and in many cases with TSD, S7A, and other antibodies which come in. Sometimes it is difficult, IgG4 staining, for example, as well. But the primary membranous glomerulopathy is characterized, and secondary as well, is characterized by presence of this subepithelial deposit. But in secondary membranous glomerulopathy, in addition, there are mesangial deposits. So if there is a problem in diagnosis, differentiation between primary and secondary membranous, EM can help. Also, acute post-infectious glomerulonephritis. Acute post-infectious glomerulonephritis can be diagnosed on the basis of ASO titers, nucleus titers, and clinical course and light microscopy. But sometimes it is important to look at the electron microscope appearance that shows this almost pathognomic humps, subepithelial humps, one here, one here. And also remember some of these post-infectious glomerulonephropathy, glomerulonephritis occur in diabetics where they occur after a staphylococcal infection, and very similar picture. So EM will be helpful in those cases. Lupus nephritis. The lupus nephritis, electron microscopy is not required for classification. The reason for that is the EM is not available, the facility is not available worldwide. Therefore, if EM was made a regular feature for the classification and essential feature of classification, most lupus biopsies would not be classified. So in this particular case example, there are obvious mesangial deposits, there are obvious subendothelial deposits. However, so this will be class 3 or 4, as my previous speaker nicely pointed out, class 3 or 4, proliferative lupus nephritis. But in this particular case, there are also subepithelial deposits. So there is a membranous component. Now, membranous component on light microscopy is difficult to identify sometimes. And the rule is that 50% of the glomeruli should have 50% of their capillary loops showing membranous component. It's not always easy if there is proliferative element present as well, but EM can help in these cases. Now, just a scenario of a case of sudden proteinuria, onset of proteinuria, which are about actual case 17 grams in a known case of thin membrane disease, and we had to identify the cause of proteinuria. Biopsy taken confirms a thin membrane disease, but in addition, look at the food processes. They're nearly all effaced. So this was, in fact, minimal chain disease. The podocytopathy is seen in minimal chain disease associated with thin membrane, well, in addition to thin membrane disease. So EM in this case has identified the cause of proteinuria. Without EM, it would not have been possible to do it in this case. Now, in addition to thin membrane disease, there are other nephritis and nephropathies where EM can identify podocyte food process effacement and then point out why the reason for sudden onset of proteinuria in lupus nephritis and IgA nephropathy and diabetic nephropathy. It's an important diagnostic process. Now, so far we've been speaking about native biopsies. Let us look at kidney allograft. Now, until about 15 years back, electron microscopic samples were not taken in transplant biopsies, were not taken, except when we suspected early recurrence of a disease like FSGS or thrombotic microangiopathy or lupus, IgA nephropathy. Even then, I mean, light microscopy helped in many cases. Electron microscopy, especially in very early recurrence of FSGS, 48 hours after transplant, massive protein appears. Light microscopy is normal, and then you do EM and podocyte effacement is seen. So that's early recurrence of FSGS. That was the use of EM in kidney allograft. For last 10-15 years, it has been known now that chronic antibody-mediated rejection, the earliest lesions, they appear on EM at least 2 years before the light microscopic lesion. The light microscopic diagnosis, transplant glomerulopathy, and other lesions are very easy, but they are late. They can be identified late. Electron microscopy identifies these lesions much earlier. So much so that now Banff recommends electron microscopy in all cases of chronic antibody-mediated rejection, either suspected or real, in all cases which are pre-sensitized, which are DSA positive, which have shown C4D positivity of peritubular capillaries, have shown GBM duplication light microscopy, which is CJ1B score 1. In fact, EM now is included in the Banff classification, EM of glomerular. And history of biopsy-prone antibody-mediated rejection, all these cases, you must do an EM on the transplant biopsy. This is an example of kidney biopsy, obvious glomerular transplant kidney biopsy, obvious glomerulitis. You see quite a few monocyte, macrophoid, mononuclear cell there, endothelial swelling. But look at the GBM, it is thin. single layer. However, you do EM, and you see clearly the thickness of the thickness of the GVM is rarification. There is new lamina densa, thin lamina densa being laid down on the endothelial aspect here. So this, in fact, case already has started the process of antibody-mediated rejection, chronic mediated rejection. At this stage, treatment should be started. Another lesion which is pathognomic of chronic antibody-mediated rejection seen in peritubular capillaries. It's a cortical, peritubular capillaries known the endothelial cell is quite effaced normally, and there is a single layer of basement membrane, whereas here you are seeing that endothelial cells is very enlarged. Cytoplasm is smeared all over the endothelial surface, inner surface, and there is multilamination. It's about 3 to 4 continuous layers in this particular case. There's some debate in BAMF how many layers should be there. 7 layers are considered pathognomic, but even before, the early chronic antibody-mediated rejection may start when there are lesser number of layers. Anyway, that would be a pathognomic feature to put you on alert for early onset of chronic antibody-mediated rejection. Now, I've been trying to sort of sell you the importance of electron microscopy, kidney biopsies, how important it is, but there are problems with the kidney biopsy. First problem is that electron microscopes are very expensive, and their maintenance is expensive as well. You have yearly maintenance contract that can run to thousands of dollars. The solution is to use cheaper, easy to maintain benchtop electron microscope. Don't go for electron microscopes, big ones which fill up the whole of the half of the room. They are required for research purposes, but if for renal biopsies diagnosis and even muscle biopsy diagnosis, you can use these recently available benchtop electron microscopes. They're cheaper to buy and cheaper to maintain. Shortage of trained technical staff. This is a serious issue, and there are no shortcuts here. They must be trained well at proper accredited programs at a good center, because it is absolutely essential to have first-class images. Otherwise, you can have misleading diagnosis if the EM images are not good enough. So that there is no shortcut here. They should be trained well. The other problem is pathologists who can actually interpret electron microscopy are not available widely. They're not, even in the Western countries, not all pathologists can do it. And the answer to that is remote online reporting. So you have, they can remote, the images, EM images can be put on a server and access granted to the pathologist, and he can look at it. Ideally, the pathologist reporting light microscopy in IF should also report EM. But if not possible, then the remote pathologist should be given light microscopic and fluorescent finding in detail, and then he can report EM. So the solution is therefore to set up EM hubs. You should set up an EM hub, for example, in a country like Egypt, several EM hubs, and followed by remote reporting. The solution really is networking. That can solve problems of electron microscopy being available much more widely. That's what we have been doing in Bahrain for several years. Now, just a few points about sampling for electron microscopy for our fellow nephrologists, especially the students or trainees. You should ideally take a sample of EM in proper fixative in all cases. That's because sample reprocessed from wax or IF are not optimal for EM. They don't give the same sort of information. Make sure the cortex glomeruli is included. This is a big thing. Often you end up with EM tissue without glomeruli. And make sure the sample is fully submerged in the fixative. This is taken, but sometimes it does happen. The sample is way above the level of the fixative, stuck to one side of the jar. Now, how do you make sure? How do you train people to recognize cortex with glomeruli? When I train in histopathology in UK, we were required as a registrar, senior registrars, to actually go and collect the sample for EM and make sure that the glomeruli, cortex with glomeruli is included. We were required to cut sample for IF, bit for IF, bit for EM. So how we trained was, we took, most pathology department get kidney organ with a tumor with normal kidney tissue, fresh. If you get fresh kidney tissue, use a used biopsy needle. Used to make a biopsy, take a biopsy from it, and then look at it with a good hand lens. You don't need a dissecting microscope. Good hand lens, you can identify glomerular, and this way you train yourself to look for cortex with glomerular. So what are my take-home messages? Is EM essential or adds to diagnosis of most kidney biopsies? Is not satisfactory. EM is not satisfactory on tissue reprocessed from wax or IF sample. IF sample is frozen, and then you stain for various immunoglobulins and complement. You process them for EM, not satisfactory. Best policy is to take the EM in all cases, as I said again and again. EM often suggests other investigation. It makes it easier to select other investigation. And of course, the establishing EM hubs and networking is the most practical solution. And these are the references. And thank you all very much for listening to me. Thank you very much. Bye.
Thank you very much, Dr. Mohammed, for this elegant presentation. For us, I think EM is not on routine basis in Egypt because of some of technical issues. But I will leave the floor for question now. If anyone having a question, please raise your hand. And until everyone prepare his question, I would like to start the discussion with you. What do you prefer, Dr. Mohammed? Do you prefer that all biopsies to be examined routinely for EM, or initially to be examined with LM and immune fluorescence, and according to the initial diagnosis, you will proceed or not for EM?
No, actually, I would not proceed to EM in all cases. I would first look at light microscopy and IF, look at the history. If light microscopy and IF suggests that more history should be sought, I will do it. But if there is slightest suspicion that EM is essential in this case, or EM may add to diagnosis, then I will recommend EM. But EM, as I said, is not essential for all cases, really, not for all cases. But in majority of cases nowadays, at least in UK and US and Europe, they are doing EM. Some of this is wasted, I think. Some of it is wasted. But in general, I would not recommend EM for all cases straight away. Take a sample, keep it, and if required, be processed to EM.
Yeah, this is very good. And do you think we will have a question from Dr. Ben? Please unmute yourself, Dr. Ben.
Thank you, our dear Prof. Thank you.
Thank you, Dr. Ahmed, for this chance. I have actually a few questions, one for the previous speaker and the other one for Prof. Mohammed. So, Prof. Mohammed, maybe you can just explain to us some pathological terms you describe in your presentation, like what is meant by scalloping and what is meant by basket wave appearance in your slide. Can you clarify that further? This is one.
Sorry, scalloping, and what else did you ask for?
Scalloping and basket wave appearance.
Basket wave, right. Scalloping is it, as if, you know, best way to explain it is when you eat ice cream, you take a blob out of the ice cream, that is scalloping the ice cream. You see, you make an indent into it. That's what happens here in this case is if I go back quickly to my.
Sorry.
This.
I was trying to connect with Dr. Mona.
The convex surface. See the convex surface here. That is scalloping. So this bit is scalloped, as if the podocyte undersurface is being scalloped. See, sometimes they call it bumping of the GBM. That's one of the essential features. The basket view is this one, where you get the thin layers, they divide and then they fuse again, divide and fuse again to give rise to, as if you have a cane basket, you know. It's not seen in all over here. So it's seen only in this area here, you see. So that just means that the lamina densa is so fragile that it is completely busted, completely, ruptured, because it is not the normal alpha. What happens in alpha chain in Alport syndrome is that during the intrauterine life, the lamina densa is composed of alpha 1 and alpha 2 chain of type 4 collagen. These are not good enough for postnatal life. So about 3 months or so, by 3 months or so, most of the GBM is replaced by alpha 3, alpha 4, alpha 5. It's a trimer, 3, 4, 5. But if there is a mutation in one of them, this trimer cannot form. So alpha 1 and alpha 2 continue to be expressed in GBM, which is not good enough. So therefore they give way and you get disappearance then. And the complication, renal complication.
Thank you, Dr. Muhammad. My other question is the difference between diabetic nephropathy and diabetic kidney disease.
All right. Yeah. Diabetic, we are running the problem. Diabetic, diabetic kidney disease, diabetic nephropathy, I mean, more or less synonymous. Our problem is diabetic glomerulopathy and diabetic nephropathy. Diabetic glomerulopathy describes the glomerular changes, which includes the Leiden classification of diabetic glomerular lesion. Whereas diabetic nephropathy will include blood vascular changes, which are quite a lot, the arteriolosclerosis, especially of both the afferent and efferent arterioles. So it is much more wider in scope, nephropathy. Whereas glomerulopathy will confine itself to glomerular conditions like presence of fibrinoid change, KWS, and thickening of the basement membrane and capsular drop. So those are, most of them can be recognized by light microscopy, except for the early GBM thickness, only electron microscopy helps.
Thank you. The last one is, what is the capsular drop?
Oh, capsular drop. I don't have an example to show you. Capsular drop is in the Bowman's capsule, you get a drop of sort of waxy eosinophilic material, which is pH positive, which is nothing but exudation of fluid from the glomerular capillaries, which sticks there. The capsular drop, if it is waxy in texture, is more or less specific for diabetic glomerulopathy. It doesn't occur in any other disease. It has to be waxy in texture. The other changes of diabetic nephropathy, as you know, nodular glomerulosclerosis can occur in other conditions. It can occur, for example, in smokers, hypertensive, it can occur. It can occur in kappa light chain deposit disease. Of course, you can then show kappa light chain deposit, but the light microscopic changes are identical. It can occur in some cases amyloid. You can get nodular glomerulosclerosis. Whereas this is more or less compatible with capsular drop, is almost more or less diagnostic of diabetes. It's not seen in all cases though.
Thank you. Thank you.
Okay, I have a question, Dr. Muhammad. How can you, when you differentiate between the diabetic nephropathy and the other associated glomerulonephritis in a case of diabetes, how you can be sure that this case, for example, is the glomerulonephritis, it's not related to diabetes, while the patient...
Yeah, that's a very good question. I mean, you're asking about dual pathology, isn't it? So the diabetic has some other additional... We recently had a case who had diabetic nodular glomerulosclerosis, known case of diabetes, no problem with the diagnosis there, but had crescentic disease as well, with necrotizing crescent, and it was anti-GBM positive.
Yeah.
We had 2 cases, anti-GBM positive. Then the other condition commonly seen is IgA, very commonly seen, IgA with diabetic nephropathy. People also have described, in fact, diabetic nephropathy with thin membrane disease. It's a tricky diagnosis. You have to be very careful in randomly selecting the area of thinness, but that can occur, yes. But it's not easy one to make. Not, for example, and also we have seen cases of diabetic with patients with long-standing diabetes, no retinopathy, no KWS lesion, had only class 2 diabetic nephropathy 2A or 2B with mesangial thickening, and they come with sudden onset of proteinuria, severe proteinuria, about 14, 15 grams, 16 grams. You do EM and you find diffuse foot process effacement. So that was an addition of podocytopathy associated with minimal change disease on top of the diabetes. And some of these cases have recent history of recent intake of NSAID. So it does occur. It's very tricky diagnosis to make. It's easier if there is a sudden deterioration of renal function. It becomes more difficult if it is just increasing proteinuria. Many cases of diabetic nephropathy, they also have hypertension, and they show FSGS in addition to. That's a tricky one to make because diabetic nephropathy should not have focal and segmental glomerulosclerosis. See, if you find segmental glomerulosclerosis with adhesion to the capsule and then podocyte hyperplasia, then you say it is FSGS occurring in diabetic nephropathy. And now that could be adaptive FSGS, secondary to hypertension and diabetes due to tissue destruction, due to increased filtration rate, So that is possible. But FSGS can be diagnosed, can occur with diabetic nephropathy.
Yeah, okay. We have Dr. Mona with us. Dr. Mona, if you want to comment.
I like the EM photos of Dr.
The internet a little bit is not very good. So we'll go back to Dr. Mona once she established the net again. I will go forward for Dr. Nagwa. She has a question. Please, Dr. Nagwa, unmute yourself.
Thanks, Dr. Ahmed, for this chance. My appreciation to Professor Muhammad. Well, this is the policy of my professor, Dr. Asim Sharif. The same to take AM biopsy, even if not indicated.
Sorry, I didn't catch it. Sorry, I didn't catch it. Sorry.
And I'm missing some of the lecture, but I will.
Please go ahead, Dr. Nagwa, until we will be back to Dr. Mona.
Okay. Many thanks, Professor Muhammad. Could you hear me?
Yeah, I can hear you. Yes, yes. No,
yeah. Same policy as you, my prof. This is Professor Dr. Asim Sharif. The same policy is to take EM biopsy if not indicated, just to save. We will need again, yeah.
If you take EM sample and you can fix it, it will fix in glutaraldehyde and then transfer to buffer and keep it as it is. It is fine.
Yes, he has a same policy. Every patient, we take the AM and fix it and leave it if not indicated. Then if the pathologist not finds the diagnosis and we need EM, we will go to EM microscopy. Thanks, our prof. My great appreciation.
Yes, yeah, that can be done. Yeah, the EM sample can be done. Some centers, they process it to resin state, which is the light microscopy. You take thin sections, 1 micron section, and the resin state can help you find some of the, can indicate if EM is required or not. But some labs will not do that. They will just keep the sample, EM sample. You don't have to proceed in all cases, yes. So the problem is that if you don't take EM sample, and then you say from the wax samples, can you do the EM? You can do it, but you can't, for example, take measurements. You can not be sure about podocyte foot process effacement. You can only diagnose gross deposits very easily on reprocessed sample. So I would, it's not recommended to do that, because let's see, the kidney biopsy is quite an expensive investigation, isn't it? So it is sort of no point saying that we can't diagnose it because DM was not taken. See, that becomes a problem, especially in children, to do another biopsy. So it's best to take biopsy and keep it. Same thing in transplant, except in very early post-transplant biopsies. EM now should be taken, samples should be taken and kept in all cases, because it is changing everything. I think BAMF will soon come with more strict regulations about EM.
Okay, thank you. Yes, thank you. The 7 rebiopsy exhibition, we faced this many times. Yeah.
Right.
Thank you.
So as you heard, Dr. Nagwa, the recommendation of Dr. Mohammed is to keep the slides ready for EM examination just in case, not to go back to the patient and to do rebiopsy. Did you mean that, Dr. Mohammed?
Yes, exactly. It's not only, it's also an invasive thing to do a biopsy again. Patients don't like it, and also an expensive one, isn't it? So it's best to do it right the first time, to keep a sample for EM, and of course, make sure the good sample is obtained, of the cortex containing glomeruli.
Okay, Dr. Ahmed Al-Bayali, he is with us, is a representative of Ministry of Health in Egypt. Dr. Ahmed, do you have a comment?
Thank you, Dr. Ahmed. Thank you.
You can comment, Dr. Ahmed. Fadl.
Thank you. I had no comment. Thank you. Thank you.
Okay. Dr. Nagwa, you want to add something or ask a new question?
Just clarification, Dr. Ahmed, we took this sampling every time, so we will not accused to be rebiopsy the patient again. Yeah.
So do you mean that you make additional biopsy for the EM from the start? So you take
yes, every patient
additional core and you keep it for EM just in case.
Yes. We saved many patients from rebiopsy from this.
Okay. Do you have any other?
Okay, thank
comment?
you.
Okay.
Thank you. My great.
Dr. Masoud, I see that you are typing a lot of text in the chat. Unfortunately, we don't have the power to see what you are typing. If you want to ask Dr. Mohammed, you can raise your hand and please unmute yourself to ask your question. Dr. Masoud? Okay, until you're ready, I will ask Dr. Faisal Shaheen from Saudi Arabia. If Dr. Faisal, do you have a comment to Dr. Mohammed?
No, it is nice to see Dr. Mohammed tonight. Actually, we work through the email and with cases, and we appreciate his excellent work. And it's nice to see him tonight sharing with you this important seminar or teaching program. Thank you, Dr. Mohammed. Thanks, Ahmed.
Thank you very much.
Thank you. Most welcome.
Dr. Masoud, اتفضل.
My question, my dear, how can we differentiate between membranous at the start and the cured membranous and the reattack of membranous glomerulonephritis?
Sorry, you're asking me? Or
so he's asking Dr. Mohammed if you can identify the dynamics of first presentation of membranous, and if it is recovering or not, and if there is recurrence of a membranous, for example, in transplant graft.
Yes, exactly. Very good question. Yes, very good. In fact, I was going to, because when talk was getting too long, I deleted that image. I shouldn't have. You can actually differentiate. What happens that it's the initial episodes of membranous get deposits which are discrete, subepithelial deposit, discrete and of same electron density. Whereas a recurrent deposit, by the time the recurrent deposit occurs, some of these earlier deposits are partially lysed, they're eaten up. And then new deposits become electron dense, uniformly electron dense. So you can sort of deduce the age of the deposit by seeing different electron densities and position of the deposit. There's as later earlier deposits, then they sink into the membrane itself, so they become intramembranous. That's how there is the enrich and the Church staging, grading of the electron microscopic changes in a membranous device. It starts from class 1, grade 1, where the EM, the subepithelial deposits are small and of uniform electron density, and there are no spurs in the around them by the laminar densa. Then grade 2 is where the spurs appear around them. Still, they remain more or less of same electron density and subepithelia. Grade 3, the deposits sink deeper into the membrane itself. They get slightly lysed. And the grade 4, when the deposits are almost completely lysed, some of them, and they're completely surrounded by lamina densa, new lamina densa, so much so that these deposits, some of them lie within the endothelial area, subendothelial area. This is class 4. So you can actually, if you see deposits at different ages, you can say that this patient has had multiple episodes of deposition. Or you can say that this patient is just recently started the process of membranous disease. So yeah, it's a very good question. And you can actually do it, yes.
Okay, very good. We'll go for Dr. Gamal. He has a question. Dr. Gamal from Libya. تفضل Dr. Gamal. Unmute yourself.
Thank you, doctor, for giving me this chance. Just I will ask a quick question about the renal biopsy and pregnancy. And there is any special advice or advice about termination of a pregnancy or any important point about this pregnancy and renal biopsy?
Well, it's beyond the scope of my sort of expertise. I think Professor Akil will be more suited to reply to this. This is in his area. As pathologists, we welcome all biopsies, but I think I can't answer the question.
So, Dr. Gamal, this is more clinical than a pathology question. Do you want to ask a direct pathology question to Dr. Muhammad, or you want to be strict to your question?
Okay, thank you, doctor. Thank you.
Okay, Dr. Iman. Dr. Iman, unmute yourself. Dr. Iman Shola, ask your question, please. We have Dr. Iman, but I don't think she is hearing us. So until she become ready, anyone else having a question for Dr. Muhammad regarding the electron microscopy or renal biopsy? I will go back to Dr. Mona. Dr. Mona is with us and having an issue with the internet. If you hear us, Dr. Mona, you can unmute yourself and speak again, because the first time we did not hear you clearly.
I have the pleasure to be joined to this very respected program, and I have every people to have clear lectures. And I enjoyed the lecture of Dr. Muhammad Tanjikar very much, with the very, very, very illustrated EM photos. And I'm ready for any question if there.
Okay, thank you very much, Dr. Mona, for joining us today. It is our pleasure that we have two eminent pathologists with us. And I would like to ask you, Dr. Mona, about the transplant acute rejection, antibody-mediated acute rejection. What is the value of having C4D staining?
C4D staining for graft biopsy, for all graft biopsy, is mandatory, but it is very important and the cornerstone for the diagnosis of humoral rejection, beside also the immunological test for donor-specific antibodies. As it is a cornerstone of the diagnosis of humoral rejection, beside the morphology in the biopsy of tubular injury or vasculitis or presence of TMA, and the positivity of C4D is mandatory. Beside this is a three cornerstone biopsy, evidence of tissue injury at biopsy like ATN or vasculitis or TMA. Thrombotic microangiopathy, and positivity for C4D at peritubular capillaries, and also the presence of positive donor-specific antibody at the serum for HLA.
Okay, thank you, Dr. Mana. Dr. Muhammad, do you think you need always to check for C4D in native kidney biopsy? When you suspect that, oh, I have to do it for this case, in native, not in transplant biopsy.
Native. It's been tried, C4D has been tried in lupus, for example. I find it useful in diagnosing very early membranous. If you are doubtful about staining for IgG, etc., C4D comes out strongly positive. We just recently had a case, very old case of membranous, possibly because it was grade 4 by electron microscopy. All the deposits that lies, we had difficulty getting a positive IgG and IgM positivity. C3 was negative, but we tried C4D, it was strongly positive. But it is not really within the diagnostic features of this, C4D. There is one entity, new entity being described now by the Mayo Clinic group, Professor Sanjeev Sethi, who has now described this entity of C4 glomerulopathy. Just like we have C3 glomerulopathy, they have described cases of C4 glomerulopathy. And of course, they do this proteomics, where they do this laser capture of the glomerula, and then they subject it to the protein analysis, which is a very expensive thing to do. They have diagnosed, they've shown that part of C4, complement 4, is there present in these deposits. Only 4 or 5 cases are seen. I've seen one case at Bahrain in a transplant, which he agrees is C4 glomerulopathy. C4 glomerulopathy is a new entity. If you Google it, you'll get it. But very few cases are described, all back from his institution. So Mayo Clinic, Rochester. Apart from that, it's not, it is present in lupus, membranous lupus, it is present. Membranous GN, as I said, is present. Some have described it in post-COVID, collapsing glomerulopathy, where the podocyte, hyperplastic podocyte, are positive for C4D. It doesn't add to diagnosis very much. One other thing about C4D in transplant I'll come to is that some transplant will be C4D negative, although there is antibody-mediated rejection, for 2 reasons. One is there is some other antibody involved, not the usual DSA. And second is that C4D levels may go up and down. So it stays there only about 2 weeks, 12 days or so. And then if the C4D levels go down, you may not find it if you do a biopsy then. C4D negative antibody-mediated rejection is well recognized now. I think Mark Haas has published a lot on it. So you have to remember, in these cases, I think electron microscopy may help because it shows characteristic changes.
Yeah, it's very good. So I will go to next question. We are in, 2 years ago, we started the era of COVID-19. And during the era of COVID-19, and we still seeing some waves again coming up from COVID-19, but also we have a lot of cases of acute kidney injury, glomerulonephritis associated with COVID-19, a lot of pathophysiology mechanisms have been explained and been theoretically exposed to tell us how COVID-19 can affect the kidney. But really my question is, do we have a special test or a confirmative test that if we took a renal biopsy in a patient with COVID-19 to be sure that is it the virus causing the glomerulonephritis or it is antibody mediated, and if it is antibody or immune complex mediated, is it really related to COVID-19? This is my first question. And second question related to the vaccine of COVID-19, also same question. Do we have any pathological confirmative test to know if the vaccine can be a part of the risk factors to having glomerulonephritis in some patients or not? Thank you.
Right. There is a big, it's almost a flood of publications about various types of glomerular diseases after vaccination and after COVID, recurrence of IgA, de novo IgA nephritis, anti-IgVM, vasculitic, rapidly progressive DN. But these are all based mostly on clinical history and histopathology. There are very few, unless you do ISH in situ hybridization for the virus, it's very difficult. There were some publications which showed electron microscopically there were these coronavirus inclusions in podocyte, and most of them have turned out to be false. They are in fact what is known as polysomes. Polysomes are normal, parts of lysosomes which are present. So it's very difficult. I don't think, classic examples were described first of COVID, post-COVID infection glomerulopathy were of collapsing glomerulopathy. That was the classic one. But then there have been hundreds of publications, but they all depend on sort of clinical history linked to onset of disease. So I'm not sure, unless you do in situ hybridization. Some people have tried antigen antibody, sort of immunoperoxidase staining as well. I don't know if it has been worked out definitively that you can diagnose pathology, histopathology, that this is COVID causing the disease.
And also the vaccine, is it any proof that we can track the vaccine in the kidney? Or is it the glomerular? Because there is some, there is some cases of membranous reported post-vaccination, post-COVID-19 vaccination, some of the vaccines. Do we have any pathology confirmative test to confirm that this vaccine actually is doing this harm or not?
No, you're quite right. They've been described, membranous, for example, with both AstraZeneca, Moderna, and Pfizer vaccine as well. There's a lot of work needs to be done for the Chinese, Sinovac thing, because it's very extensively used in UAE, has been used extensively, and we have quite a few cases of various glomerulonephritis and complications. We've not published them yet, but I think it should be published with the Sinovac. But as you say, all vaccines have been associated with all sorts of kidney diseases. Really, there's a good review somewhere. I'll have to search it out, take it out. Good review about pathology of various COVID infection and vaccination. Fairly recent review, I think 2021. I think KI it was. That was take it out.
Yeah. Okay. Well, I have a question from Dr. Ben. Dr. Ben.
Thank you, Prof. Ahmed. I just have also to have one clarification on COVID pathology collapsing FSGS. Can Prof. Mohammed explain to us the term podocyte dedifferentiation in that pathology? Podocyte dedifferentiation.
Podocyte dedifferentiation, yeah. There's a question what podocyte dedifferentiate, or they are simply lost and replaced by parietal epithelium. You see, there's a question about that. And there are some markers which have been touted both ways. So the WT1 should be present in podocyte and it's absent in collapsing. And in some cases, you see presence of Ki67 proliferation marker in the parietal cell epithelium. CD44 has been used. So the arguments on both sides. So I don't think it has helped a lot in immunohistochemistry has helped a lot at this stage in determining what is happening. The general view now is that collapsing occurs in general because of loss of podocytes, which are replaced by proliferating parietal epithelium.
Okay. Before we lose the line of COVID-19, I would like to ask Dr. Mona, did you see cases in our series in Urology Center in our transplant? And
Yes, Dr. Hamad.
is it related to COVID?
I'm just asking you to allow me to comment for this, and I have two questions. First, the comment, I have two cases. One COVID, two cases. One was transplanted patient to your clinic and to our lab. He was anti-GBM. He presented by acute renal failure post-transplant by 2 years, and the biopsy proved to be that have anti-GBM. This one case. The second case was non-transplant patient, and post-COVID by 3 weeks, he presented by lupus nephritis, a highly active class 4 proliferative lupus nephritis with full house immunofluorescence. These two cases I saw, I examined post-COVID, and like if Dr. Muhammad Tanjikar like to comment for these two cases, and I have two questions for Dr. Muhammad. For membranous nephropathy, when we have C4D for staining, the positive control to test C4D is membranous. We should experience the test for membranous. And I like for membranous nephropathy to ask Dr. Muhammad about his experience or his comment on the anti-BLAR2 phospholipase A2 receptor. I like to know if he regularly stained membranous cases for the anti-phospholipase A2 receptors, and I like to hear from him.
Right. We routinely stain for BLAR2R. We also use IgG4, of course, and we use TSSD7A as well. Or figures, I'm just giving you figures off my head. Most of the cases of primary, about more than 90% are BLAR2R positive and or IgG4 positive. TSD7A is positive in very few cases in our database. Some cases are negative BLAR2R and only positive IgG4, but according to literature, that can happen. Now, we have not used NEL1 and exostocin 1 and 2 yet. So that remains. So we do use BLAR2R, BLAR2R immunofluorescence is very easy to do. You have to remember that sometimes the serum levels of BLAR2R may disappear, but the tissue biopsy, the kidney does show staining for it. So apparently it remains bound to the glomerular capillary wall, whereas there's very little left in the serum circulating. What else did you ask? You asked for.
She was reporting two post-COVID cases.
I've not seen a single case. Yeah, I've not seen a single case of SLE in COVID. I can't comment on it. But there are cases reported, obviously. I think you should report it. It's not uncommon. It's not that common, really. If you have a good workup, you should report it.
Thank you, Dr. Muhammad.
Thank you very much. And it is my honor that we have our Dr. Muhammad and Dr. Professor Mona with us today. We had a very nice night with histopathology from LAM to electron microscopy. I would like to thank you all. Thank you very much, Dr. Muhammad, for joining us today. Thank you very much, Professor Mona. And I would like to thank all our professors and attendees for joining us today. And I wish you all a very good night. And we have to end our session. And thank you all and see you tomorrow, inshallah. مع السلامة.
Thank you very much, Professor.
Thank you, Dr. Ahmed. We have learned a lot from this very interesting session. Thank you very much.
Thank you. Thank you. مع السلامة. مع السلامة.